There we go. Well, thank you. So this study has an interesting history in that it originally started in the Northwest Center to Reduce Oral Health Disparities, because we find that women and minorities more often suffer from dental anxiety, or at least admit to suffering from dental anxiety, than do male Caucasian majority. And so we proposed to basically take our dental fears research clinic at the University of Washington and move it into the field, to put the clinic in rural areas where psychological treatment wasn't readily available. And to do this, we wanted to work with private practitioners who were the go-to people in those rural areas. About the time we got funding for this project, you all got funding for Northwest Precedent. And so I came to you as a group and asked you to adopt my study, and I was very pleased at the level of interest that you had in doing this. And so this became study 4 of the Northwest Precedent, as well as one of the studies in the Northwest Center to Reduce Oral Health Disparities. So it's about 5 to 10% of the general population that actually reports canceling or avoiding dental appointments due to anxiety. So you've taken away money as an issue, you've taken away transportation as an issue. They're just too scared to be there. Now, as a psychologist, I can tell you, I chose dentistry because this is very easy to cure anxiety. All those other things that clinical psychologists work on, schizophrenia, depression, those are tough problems, and it's really hard to make a difference in those people's lives. Simple, specific anxiety, very easy to cure, and we have textbook methods, and we can cure literally in 1 to 2 therapy sessions, make a world of difference in these people's lives. And yet, when you talk to dentists about what they do in their offices, they often tell you that they'll give Valium or another benzodiazepine, they'll refer a patient to sedation, or refer out to another clinic. And if you ask them why, it's not because they don't believe in behavioral therapy. They tell you that there's just too much time involved in doing it in their office, and they don't feel that they have adequate training to do this therapy. Well, it's almost 20 years ago now, I want to say, in the mid-1990s, the Dental Fears Research Clinic developed the CARL program. This stands for Computer-Assisted Relaxation Learning. Now, Brooke Ladsky put study in a box. This put Dental Fears Clinic in a box. This is basically a computerized version of the therapy that's done in the Dental Fears Clinic. It's based on systematic desensitization, but it involves gradual exposure over time to the feared object. In this case, the program was written to address what is commonly cited as the most fearful for patients, the dental injection. I want to take you through a bit of the CARL program to show you what this is like. And you'll hear the clicking sound of the mouse. We explain to patients that this is a self-paced learning program. So they're going to go through therapy at their own pace, and this should take them through the first steps at addressing their fear. The program starts off by demonstrating physical relaxation techniques as well as cognitive coping strategies. And the way it works is by showing a therapist interacting with a model patient to explain the techniques to them. I want to show you a brief clip from CARL.
We're now ready to begin teaching you the foundation of overcoming a fear, physical relaxation. A lot of patients, when they're in the chair and they're somewhat anxious, tend to kind of tense up and grab the chair, sort of hold on for dear life. Have you ever done anything like that?
Yeah.
Well, physical relaxation is one way of sort of becoming more relaxed, and it helps you get through a difficult situation like getting a dental injection. Now, the first skill in physical relaxation is deep breathing. And deep breathing is a very simple but effective strategy to use. And it consists of taking a nice deep breath in, like this, 1, 2, 3, 4, 5, and then letting it out. 5, 4, 3, 2, 1. Okay.
So the program goes through these physical relaxation skills: deep breathing, muscle relaxation. It goes on with a similar video explaining some cognitive coping strategies such as distraction. So common things that you learn in dental school and you probably talk to patients about using, but demonstrating to them and having a patient model these techniques. What Carl then does is to take patients through 7 video segments, and at the end of each segment, the patient is asked to rate their anxiety. If they're too anxious to make it all the way through the video, they can click a mouse button and actually stop the video, and then Carl assumes that their anxiety is very high. So we explain to the patient that the goal of the program is to repeatedly watch each segment. So this is systematic desensitization. It's based on exposure. They repeatedly watch until their anxiety is low enough to move to the next segment. And the patient is instructed to self-rate their anxiety on a 1 to 9 scale. So they're asked after each video, how anxious were you? Anxiety reports of 4 and below are considered low anxiety. The patient is allowed to proceed to the next video. Anxiety levels of 5 and above are considered high. The patient is asked to stop, use their relaxation techniques, and move to an earlier video that they successfully viewed. There are 7 2-minute video segments, and each of these depicts a hygienist talking to a female patient, explaining the dental injection procedure. The patient is shown to be nervous, but successfully using her coping strategies to get through each step. So we begin by showing the syringe, the needle. We proceed to explanation of a topical anesthetic. We then show the needle. We then simulate an injection with the cap on the needle, simulate an injection with the cap off the needle, and then there's actually video of the patient receiving an injection. And the anxious patient is watching each of these steps. I'd like to show you a demonstration of step 2. So this was the second video the patient would watch.
Now I'd like to speak about the needles that we use to give the injection. Okay. The needles come in a sterile encasing that is sealed. Okay. They're very, very sharp, and we only use them once or twice in the mouth, and that's all, to keep them sharp like that. Now I'm going to have to put this syringe together to show you what the needle is all about. Okay, now we're going to pull off the cap. Pretty long, isn't it?
Yeah, it is.
People wonder why it's so long. A lot of people think that because it's so long, it's going to go clear up to the hilt, it's going to go clear into the brain, okay?
Yeah.
This is not so. I want to show you this little bevel at the end. Can you see that little bevel, how it's at an angle?
Uh-huh.
When we inject this into the tissue, we don't have to go any farther than that.
Oh, that's
Remember,
good.
all we've got to do is deposit the solution into the tissue around the nerve. We don't have to go deep, okay?
So here's a frame of the patient in the video looking at the needle, and another frame of the same patient receiving an injection. My favorite segment is actually, and I think these guys here may have even been involved in filming some of that are here filming today. The patient has the needle coming straight at them, and it's the view of the patient seeing the needle coming straight towards you. And that always gets a lovely anxiety response from them. At any time during these videos, patients can click a mouse button, the video will stop, and they will then be cued to use their relaxation techniques to overcome their anxiety. If they make it all the way through the video, The patients rate their anxiety on a 1 to 9 scale. If the anxiety is rated as a 5 or above, then the patient is again cued to use relaxation techniques and then taken back to an earlier video that they were able to make it successfully through with low anxiety. And then they repeat the following video. So they do this at their own pace, repeatedly. When we used this program in an earlier study in our own clinic, we didn't expect this to work very well. We had previously had live therapists working with patients. We didn't think that the program itself would be effective. To our surprise, we found that patients were much more willing to admit anxiety to a computer program than they were to tell our hygienist that they weren't ready to proceed. It's almost as if you have a live therapist there, you feel like you're wasting their time. You're making them repeat and using up their valuable time, and you should just push ahead when you're not ready. However, patients using this computer program were willing to admit a high level of anxiety and then repeat the videos again and again as needed to reduce their anxiety. Carl gives individualized feedback to the patient based on their self-reported fear levels. So if they're reporting their fear levels as low and they're moving ahead well, Carl will tell them that you're making great progress, and as you near the end of the program, you're about to go through the final segment in which there will be an actual injection. So the patient's warned that this is coming up, and Carl suggests to them that they take a moment to prepare, use the relaxation techniques. On the other hand, if the patient is reporting too high of an anxiety, the Carl program gives them feedback. Your anxiety is too high to proceed. You need to use your relaxation skills, and we strongly encourage you to practice them as you go through. Carl even gives you feedback if the program has a feeling that you're rating your anxiety too low and you're really trying to push through. Are you sure you're ready to proceed? Remember, the purpose of the program is to repeat, and they're given an opportunity to re-rate if you're proceeding too quickly through the program. And feedback is thus tailored to the patient's response. So in addition to the program that we developed here in the United States, and this time we do mean United States, and University of Washington, there was a version of the Carl program developed in the United Kingdom. And they actually reshot our video footage with British accents because they felt the language was different in the two countries. Both of these programs have been used and assessed with measuring patient anxiety before and after using the program. And both have been shown to reduce dental anxiety. However, this was always in an academic setting, so it was in Guy's Hospital in London or at the University of Washington. And there was never a comparison to a standard of care that you might use in a private practice. So what was really needed was an effectiveness study for this program, a randomized controlled trial. So the aim of study 4 for Carl was to test the effectiveness of this program in dental practices against what you would normally do in your own offices to try to reassure a patient who had dental anxiety. Now, there were 7 precedent practices that participated in the Carl study. There was actually an 8th practice where we never received any patients who called in from that town, and that was Dr. Claymore, who mentioned that the town was small and you know everybody. And, none of them would admit fear to us, so we've left you off. But these are the locations and types of practices that participated in the study, and I thank all of you. The way this worked was different than other precedent studies. So in most precedent studies, you recruited your own patients into the study. But we were specifically trying to target people that don't go to the dentist, aren't regular goers. So we wanted people out in your communities who were actually avoiding dental care. We wanted them to now come to your office, and we wanted them to be comfortable with dental care. So we recruited fearful patients in the community by placing advertisements in the community. We also put posters in the dental practices in case some of your own patients weren't admitting to fear and actually wanted to be in the study. But the vast majority of patients came in through local media advertisements. So interested participants phoned a toll-free number that connected them to a study coordinator at the University of Washington. The study coordinator gave them information about the study over the phone and determined that they met initial inclusion criteria. So these patients had to be generally healthy with no untreated systemic conditions. They had to be fearful of dental injections, and we wouldn't accept anybody currently taking anti-anxiety medications. But if they met those criteria, we explained the study and they were interested in participating, then we referred them to one of your local practices or to our own FEARS clinic, as I'll describe later. We sent your office managers the names and contact information of these individuals, and we asked you to schedule them for a screening appointment to come into your office. So once the study moved into your office, this is an overview of how it looked. The patient was first given a health history to complete and consent forms, but then they were sat down at our computer and completed a computerized fear survey to determine that their anxiety levels were high enough to participate in the study. And interestingly, almost all of the patients out in the community practices that appeared qualified for fear. But here's an interesting difference between an academic setting and a university setting. When we moved this into the FEARS clinic, there were a large number of patients who came to the FEARS clinic who didn't qualify. And we think this is because you're used to going around an academic center, seeing that there's a study going on, and these are basically people shopping for studies, versus those out in the community that are truly interested in the therapy. But in your hands, most of those patients had the kind of fear levels we were looking for in the study. If they had the fear levels that we were looking for and qualified for the study, they were immediately randomized within a practice to study condition. So if they qualified, the computer would give them a green light. There's a button that the practitioner or usually the office manager would hit, and it would assign the patient to condition. This was a single-blinded study. The patient was told, this is the condition that you'll be in. You'll come back on another visit and you'll start working with the CARL program, or you will come back on another visit to meet with an office staff member and discuss an informational pamphlet. We developed the informational pamphlet by looking on the web to see what dentists said on their websites about dental injections. And we found some very reassuring information about dental injections that repeated over and over and over again across a number of dentists' websites. And some of those dentists credited dental websmiths with the material. And so I contacted dental websmiths for permission to use their information in the pamphlet, which was basically reassuring information about pain control and modern needles being better and things like that. But nothing about relaxation techniques, nothing that we considered explicitly therapeutic, just very reassuring about comfort levels during injections. And so those were our two conditions. Patients came back on a separate visit following the screening to participate with either CARL or the pamphlet. With the CARL visits, we allowed them to work with the computer up to 9 dental visits. We said we would cut it off at 9. In the academic setting, that was the maximum anybody ever took to get through the computer was 8 visits, and so we felt allowing 9 would be sufficient. In fact, you'll see that nobody took more than 3 visits following the screening with the CARL program to get through. The pamphlet visit by study design was 1 visit. Immediately after completing the intervention, either the Carl program or the pamphlet, the patient retook the computerized fear survey to get new fear levels. They were also invited for a free dental injection to occur on another appointment. So let me tell you how this study proceeded. I should mention we also we had a practice in Montana where we referred 7 patients from Montana to the practice, and Jane Gillette worked really hard to get those people in, but those fearful patients talked with their feet, and they never showed up in Jane's office, not once. And she finally got fed up and asked to mail my computer back to me. For the other practices, you can see the number of patients that we referred to the practice and the number of patients enrolled, which in the precedent practices largely represents the people that showed up in the office. If they showed up, they largely qualified, with very few exceptions there. So there were a total of 172 patients in the study referred out to the offices. There were 84 patients that were actually enrolled in the study, and 68 of those completed the intervention phase. Working in the FEARS clinic, I can tell you this is a difficult group of people to get into the office to treat, because the very thing that qualifies for them for the study makes them not want to be there. And so this wasn't all that surprising. But because recruitment was going slowly, we did add the Dental FEARS clinic as another site in the last year of the study, and those represent 42 of the patients who completed, about half. So what do we know about the 16 that didn't complete the intervention? I thought that people would think this computer program was so wonderful that they would just come to the study wanting to be in the computer program, and if they didn't get that group, they would just drop out of the study. And so I was kind of thinking that might be a measure as well, or a problem that we'd have to deal with statistically. But in fact, dropout was similar in both conditions, the pamphlet group and the Carl group. So the pamphlet, being assigned to the pamphlet group didn't discourage the patient. This seemed like a normal, acceptable thing for them to do. It seemed reasonable for them to talk with a dental assistant in the office, go over the pamphlet, and we certainly had reason to believe, and I'll show you that it did, help them. There's much therapeutic value to coming into a visit, meeting with the staff, and actually having no dental work done, and having your anxiety reduce for that reason. And so people accepted that, similarly to the Carl program. The group that dropped out was slightly younger, they were less educated, and they were more fearful. They were the higher fear group than those that stayed in the study. For those that remained, though, there were 68, and conveniently, there were 34 in each condition, the 34 in the Carl group and 34 in the pamphlet group. And throughout these presentations, everybody's been praising randomization, and I'll continue to do that. The groups were very similar, numbers of females, race, education, age, and initial fear levels. As what we'd expect in private practice, these were largely white and college-educated patients. And as we would expect from those that admit to dental fear, they were largely female patients, majority female. So as I said, 34 patients completed the Carl program, and they did so in 1 to 3 additional visits. So they came in for the screening, and then they did 1 to 3 more visits to work with the computer program. They viewed a minimum of 7 videos. That's the minimum you have to view to complete the program, and up to 34 times watching those videos through the Carl program. The average was 14, or about 2 times per video to get through the program. Whereas the patients in the pamphlet group talked with a dental assistant for 1 session by study design. This gives you an idea of the kinds of questions we asked in the computerized dental fear survey. This is Humphries' modified dental anxiety scale, which despite its brevity is one of the more sensitive scales to manipulation of dental anxiety. It's very simple. It's got 5 questions. Each is scored on a 1 to 5 scale. And the questions are all about how you would feel as a patient if you went to the dentist tomorrow and had each of these things happen. So if you went to your dentist for treatment tomorrow, how would you feel? Not anxious, slightly anxious, fairly anxious, very anxious, extremely anxious. How would you feel sitting in the waiting room, having your tooth drilled, having your teeth scaled and polished, and having a local anesthetic injection in your gum above an upper back tooth? How would you feel? So the minimum that you can score on this scale is a 5, endorsing 1 for each item, and the maximum that you can score is 25, endorsing 5 for each item. So what you see here is on the left side, the anxiety levels for the computer group and the pamphlet group prior to intervention. That's at baseline when they came in for screening. And actually, you can see these patients were quite anxious. So they were scoring about a 20 out of 25 on that. So, and this is on average. So about a 4 out of 5 on each of those items consistently across. So they didn't just have needle fear. They weren't just afraid of dental injections. They were afraid of the dentist and the various aspects of the dentist. And then what you see on the right-hand side are 2 bars indicating fear levels on this measure after working with the Carl program or working with the pamphlet. I should tell you that in both cases, there is a decrease in anxiety from baseline. So both the pamphlet group and the Carl condition got better from baseline, just as we'd seen in other studies. But the difference between the Carl group and the pamphlet group is whoppingly statistically significant. So those that worked with the Carl program had greatly reduced anxiety. So they're going down to about a 12 on that scale from about a 20, whereas the pamphlet group had much more moderate decreases in anxiety. We also gave a longer fear survey. This was a 20-item measure by Kleinknecht. It's the dental fear survey. And it's also scored 1 to 5 on a Likert scale, as is the Humphries measure. And so this scale ranges from a low of 20, 1 on each item, to a high of 100, 5 on each item. And you can see, again, on this scale, people had fairly high anxiety levels, about 70. And those working with the computer had greater reductions than those working with the pamphlet. We also assessed with our own needle survey, which is an 18-item measure, also scored 1 to 5. And again, we see greater drops in needle fear, specific to needle fear, with the computer than with the pamphlet. But very few participants accepted our offer of a free dental injection with no dental work and no payment. Go figure. In previous work, again, in an academic setting, we had patients agree to do this, to come back for a free dental injection. We told them this was a graduation exercise. It's actually a beneficial part of therapy. However, in that previous study, we actually paid people not to get the injection, but to appear for the appointment. For various reasons in the PRECEDENT study, we decided not to pay the patient to appear for the appointment. One is it was against PRECEDENT policy, at least at the time, to pay the patient for participating. Secondly, the dentists involved in the study were uncomfortable with paying the patients to be there. And when we'd published other works, reviewers had complained that we were paying the patient to appear, and this might be coercive. So once they're in the office, they may feel socially compelled to do the dental injection, that it wasn't a true test of their ability to to go through with the dental injection. And so there was really no incentive for the patients to come back for the injection, and most of them didn't. However, the trend is very promising. Again, it's on that P is 0.056 or 0.06 level with a chi-square, that the computer, in the computer condition, twice the number of patients came back than in the pamphlet condition. But due to the low number doing this, it doesn't reach statistical significance. Overall, I'm happy to conclude that you can use a computer to help people overcome dental anxiety. The psychological treatment did reduce dental anxiety more than reading a pamphlet, although just coming into your office was certainly helpful for patients. Nevertheless, there were a large number of patients referred to dental practices who didn't pursue participation in the study. So again, only half of those that we referred to the practices actually ended up enrolling in the study, and that was not typically due to meeting inclusion criteria. It was due to them not showing up in the office. So this anxiety was preventing them from even coming to the study. Furthermore, even for those that showed up in the office, 16 out of the 84 who enrolled in the study didn't complete the study procedures, and the relatively higher fear levels in those 16 suggest that dental anxiety was likely a factor for them not completing the study. And even when the patients did enroll and did complete the intervention, there were very few that agreed to a free dental injection. Sale on dental injections. Now, all of these aspects are par for the course, and for those of us working with anxious patients, we know that they're difficult in this way. The very fear that they have that you're trying to treat keeps them from coming in. Nevertheless, because of these issues, it really suggests that an online version of this program would be useful for patients. Something they could use at home to help them get through the initial anxiety and then get to the office. We don't feel that it would be as therapeutic because part of the therapy is coming to the office, interacting with your staff, driving up, parking, interacting with your staff, smelling the smells, hearing the sounds. That's all part of that exposure therapy. But if you can't get them in the door to give them that therapy, we think that having an online version would be a useful thing. We need to disseminate this program and this type of therapy. It is useful for patients. We've shown reductions, at least in self-reported anxiety levels, and it looks like it reduces, it increases their ability to get a dental injection, but we have more work to do, as always. So I wanted to thank the PRECEDENT practitioners that participated. I wanted to thank my colleagues as well. Lisa Heaton has worked with me on this study for a number of years. And I also want to thank two funding sources out of NIDCR that funded the Northwest Center to Reduce Oral Health Disparities and also the PRECEDENT grants. And thank you for your attention.
Thanks, Sue. Questions, please. Yep.
Is the Carl disc available?
Well, one thing about Carl being 20 years old and then resurrected 10 years ago is that it's not up to date for current operating systems. In fact, it became out of date during the course of the study. What we do have available are the videos. And so what I've been sharing with people to date are the videos that they can use for the patients. But right now what we're doing is seeking money to get something online so you could just refer your patient or use it in your office online is our goal. And we're also currently working on development of sort of a kiddie Carl version, something for children to watch with their parents current pediatric dental practice is to kind of hide the injection from the child and not tell them. And we're trying out our method of actually confronting them, you know, here's what it is. But you wouldn't want them talking about going through the tissue and into the brain to a 5-year-old. And so we're working on a much more kid-friendly version that we can do. So those are our 2 goals. But I'd be happy to make the videos available if you're interested.
Do you have any information on any of the graduates, whether it's through your clinic or with the PRECEDENT group, of people that then actually went and had dental care done?
Yeah. In this study, we didn't follow up on whether they received dental care. I do know in Dr. Hagi's office, many of the graduates became patients. And he was our first office that we enrolled, and he gave us that feedback that these patients subsequently enrolled and became members of his office. When we've used this in the academic setting, we tracked patients for 1 year out, and we saw that this decrease in fear was maintained over the course of an entire year. So that was reassuring. For patients that, what was interesting is that they didn't always visit the dentist. And if you looked at what the reasons were, then financial barriers and some of the other barriers came into place. And of course, there are some patients that don't get better. So we've also looked at those aspects. And having depression, having other mental illnesses makes people not get better and not maintain these gains as well. But we haven't looked at it within the PRECEDENT study.
Great presentation, Sue. Has this been used for post-traumatic stress disorder, somewhere you kind of continually expose the individual to?
Absolutely.
Okay.
Yeah, so a big movement, and it's gone more in the virtual reality domain for post-traumatic stress disorder, is exposure therapy. And a lot of the way that field has moved is to use virtual reality, where you have the sounds and the smells and the sights and the vibrations in treating the patient as well, and it's very effective there. My own approach has been to go more low tech, because I want something you could deliver on a cell phone. You could deliver over the internet. The virtual reality idea of having a helmet and having to do it in the office doesn't give you the access to care gains, because what happens then is you need the therapist. You need it to happen in the office. And if we have just videos that play, you know, it can happen in the waiting room on the cell phone, it can happen on the tablet, it can happen in the library, it can happen at home. So the portability idea of going low tech is very appealing. So that's the direction we've gone. Whereas for PTSD, they've tried to recreate the situation and make it as real as possible in an attempt to make the therapy more efficacious.
So when they were seeing the explanations on the screen and directing them, that was just reading it. There was no vocal that went along.
Correct.
So if there was a vocal that went along with that, a soothing voice explaining that, instead of just reading that text, would there be a further benefit?
Yeah, one issue that we had through the Oral Health Disparities Center is we tried to take this program into the migrant communities, where we realized there's a huge need in the Hispanic communities. And we translated all of this stuff into Spanish and kind of rolled it out in the communities. And what we found was that literacy was a huge issue, because they don't not only read English, they don't read Spanish either. And we found that with the consent forms, with all the scales that we were using. And so I think to get some of these populations that might need this program, we would have to go through making it completely audio-based. And certainly with the children, that's what we're doing. Good point.
Other?
So if you had, say, a healthcare economist look at this and then maybe compare it with a tablet of Valium and maybe IV sedation, where would this fall out, do you think, if you were looking at this as a treatment modality, cost effectiveness, and so forth?
Valium's very cheap, But you have the aspects that you can't really let the patient drive home by themselves with that. They need somebody who's going to drive them because it has issues with impairing them. You have some interactions with it. It's a pretty safe drug. A lot of times people go to IV sedation, which then has inherent risks associated with that. And there's evidence that if you just do IV sedation, they don't get over the fear. So then you're doing that again and again and again. If we can find a way to get this on the internet and available to patients, this could potentially be free. The problem that a lot of dentists had with using this in office, even though I think it's more effective in that setting, is, was very interesting, was having space for it. Because we wanted a place where they could work privately. And a lot of you are utilizing your space incredibly well. I mean, we were in break rooms, we were in little libraries, we were in little consult rooms, and that was more of a limitation than I realized. So that was a cost to the dentist, was the space. There wasn't a lot of staff time involved because the patient worked themselves, but nevertheless there is some staff time involved. So those are considerations for cost. Space being more of an issue than I realized going into this, and then a minimal amount of staff time.
Thank you. Okay. Thanks, Sue.